classification, and CAD is not always a focal disease, and PCI in its answer, it is much more complex than just fixing just a single stenosis. We have to address atherosclerosis as a systemic vascular problem. It has widespread events happening. It is progressive over the lifetime horizon. And despite the fact that we are giving aggressive secondary prevention therapies for risk factors, for lifestyle, for optimal medical therapy, now we have evidence that has challenged the role of PCI in stable ischemic coronary artery disease. Two major trials in this regard are the Courage and Ischemia trial that has led to the intervention in the stable angina to become a shrinking market. Why it happened? Because our approach of revascularization should be more thoughtful. We have to think when, why, how, and how to do it well, especially in stable ischemic coronary artery disease, where we have to give the best of results so that we do not convert a patient of stable ischemic heart disease to a acute coronary syndrome patient. The two trials in this regard are the Courage and Ischemia trial. Just in a nutshell, the Courage trial that compared some 1,000 patients in the optimal medical therapy arm versus around 1,100 patients in the PCI arm, randomized in 1:1 fashion and followed up for 7 years and 15 years, did not show a significant difference between the patients, those who underwent PCI versus without PCI. The event rate was almost similar of 24% over 15 years. Similarly, most recently in 2020, we have some 2,500 patients randomized in this parallel open label trial, the Ischemia trial, that excluded patients of left main disease documented on a CT coronary angiogram, and then randomized the patient into an invasive arm versus conservative arm. And the primary endpoint was similar between these two arms with a p-value of 0.34. So it again reiterated the same opinion that invasive arm was similar to the conservative arm. But if we see more carefully, we dive in more deeply, and we see the complete revascularization rate, especially as compared to anatomically complete revascularization based on angiogram alone, or a functional complete revascularization based on FFR alone, we see that those who achieve a complete revascularization, especially have a rates of 11.9% if done anatomically, as compared to 13.1% if done functionally with the use of FFR. And FFR, though it has turned out to be a gold standard, it has a wealth of long-term outcome data, there are certain limitations of FFR in the stable ischemic heart disease as well as ACS patients. We do not have any information on the anatomy, morphology of the lesion, and it is extremely unreliable in serial stenosis and ACS. And just physiology itself does not rule out edge dissection, suboptimal expansion, stent malposition that flies beneath the FFR radar. And while addressing these diverse spectrum of patients, we have to understand that we have a lot of stable ischemic heart disease patients, those who have actually had a ACS event earlier, a phase that went asymptomatic earlier, and they are now presenting to us as stable angina. So in a nutshell, we have to understand that CAD progression is dynamic, it is unpredictable. In a lot of cases, it unexpectedly leads to MACE, despite whatever therapy that we have, guideline-directed medical therapy that we have for secondary prevention. And hence, it comes to a point that even in stable ischemic heart disease, we should try to find out what a vulnerable plaque actually is, so that we can find out those high-risk patients in those stable coronary artery disease patients. And more importantly, the recent concept has shifted from identifying a vulnerable plaque and now trying to identify who a vulnerable patient actually is. It's the focus has moved from plaque to the patient, because sometimes we might address a local factor that might make a plaque unstable, but a lot of events are occurring in the non-culprit plaques as well, especially if the patient has systemic factors contributing to thrombosis like renal dysfunction and diabetes. And we have to, I'll exemplify two very important, beautiful examples. The first case is a 52-year-old diabetic male. He presented to us with a chest pain of 3 days, but for the past 2 months. And this was the angiogram. The angiogram showed a mild disease in the LAD, almost any non-significant disease in the left circumflex, but the RCA had a mid-moderate to severe stenosis, and in view of unstable angina, the RCA lesion was fixed. I went back home. I got a call after few hours, possibly 5 to 6 hours after the PCI, that the patient has chest pain and the ECG shows anterior leads ST elevation. And this was to a surprise to me, so much so that I said, you've sent the ECG of the wrong patient, because we did PCI to RCA. And when we took the patient for a check angiogram, the LAD was occluded. So a artery that was flowing a few hours back just got occluded, despite the fact that the patient was on anticoagulation as well as antiplatelet within the hospital. And we did PCI to LAD, but before that, after thrombosuction, we did a IVUS run to see actually what has happened. And if you see at the site of stenosis, there is just a fibrocalcific plaque. It was extremely mild, and on the other hand, there was a fibrofatty plaque with a necrotic core that was abutting the lumen. And if you see angiographically, it was not more than a mild disease. And even with intracoronary imaging, the plaque burden was just 30% of area stenosis. But since it was a vulnerable plaque, it got ruptured. So we really need to address and we understand that a lot of events are occurring in mild plaques, in moderate plaques, especially those that are fibroathromas, defined as a presence of more than 10% confluent necrotic core, if they are seen in an arc of 30 degrees in 3 consecutive frames. The second case is also a similar example. I won't go into the details, but the history is important. It is a diabetic 38-year-old male with a TMT positive kind of a chest pain. And if you see this plaque, this is an eccentric plaque, but you see signal-rich confluent punctate speckles of seen on OCT. These are nothing but macrophages. So a lot of inflammation and inflammatory substrate might make a plaque unstable, despite the fact that the plaque has got very minimal stenosis. And more recently, we've got more detailed trials like the combined OCT FFR trial that actually randomized patients, even plaques, those who are FFR negative, into a TCFA positive on the basis of OCT. TCFA is thin cap fibroathroma, documented on a optical coherence tomography imaging, versus TCFA negative on OMT. So it is just an observational arm, and it has been seen that the outcomes in the short term as well as long term are significantly higher. The MACE events are significantly higher in patients, those who have an underlying TCFA. And with this long-term data of even 5-year follow-up, we really need to actually address these lesions, understand that the TLR at long-term follow-up is significantly higher because of various episodes of subclinical episodes of silent plaque disruption. And this understanding of vulnerable plaque, when it was given first in 1989 by Muller, it has really changed its phase in the recent era with the advent of CLIMA trial, PROSPECT trial, and we really now have moved to finding a target population that is capable of having a vulnerable plaque inside. These are those patients, those who have a cardiac CT high calcium score more than 400. These are those patients, those who have a low attenuation plaque burden, those who have had a past history of MI, and all those patients, those who have diabetes mellitus. So this is extremely important to find such patients. And I'll just mention one slide. If you look very carefully, in this slide, the right lower corner, you see the hazard ratio of a diabetic patient with TCFA versus diabetic with no TCFA. The MACE is 3.8. So having a diabetes gives a hazard ratio of 3.6 versus TCFA alone in a non-diabetic patient gives a hazard ratio of 2.4. So diabetes, the history of diabetes in itself is an extremely high risk characteristic that really needs to be taken care of in almost all coronary artery disease patients, whether stable or unstable. And in the recent era, it is not very difficult to link these vulnerable plaques to heart events. And in the post-ischemia world, we have a lot of evidence, especially with this combined OCT FFR trial, that the plaque composition, the stability really needs to be questioned, and it may not be tightly linked to myocardial ischemia. To summarize, the epidemic of diabetes is linked to obesity. We really need to work hard on reducing the risk factors at a primary level, but we also need to work hard on reducing the secondary events by addressing the risk factors in totality. And despite the fact that the improvement of secondary prevention strategies, we don't see a decline. And a recent resurgence in this morbid ischemic complications and statistics leads us to think that we have to give primary prevention to all patients, but also focus on secondary prevention. And we are witnessing really fortunate advances in this era. We have an array of antithrombotic strategies, from aspirin alone to clopidogrel alone on the basis of Capri trial, combination of aspirin plus ticagrelor in Themis trial, a combination of aspirin plus rivaroxaban in Compass trial. We have seen novel lipid modifying therapies with the availability of PCSK9 inhibitors, small insertional RNAs, excellent use of DPP4 inhibitors, SGLT2 inhibitors, that has given us significant reduction in the secondary event prevention to the tune of 9.8. And we are even witnessing an era where DAPA is now actually labeled as an anti-aging drug. But the adoption in clinical practice is really bad, and we really need to work hard to bridge this gap, despite the fact that the cost of medications has reduced. As physicians and as cardiologists, we really need to address the fact that diabetic patients really signify a very, very high-risk population, and identifying unstable plaques within this category of stable ischemic heart disease patients is extremely important to give the best level of care. Thank you very much.
Thank you, Tanush, talking great talk. Any comment from Dr. Rajiv or Dr. Pathak?